Is there a question to ask?
Hello, Dr. Anuya.
Hi.
Good evening. How are you?
Good evening. We are all good.
Thank you for joining us today. Great to have you here.
Thank you. My pleasure.
And good evening, all our attendees. I'm Shriyal Setumadhavan, the Executive Editor of Aesthetic Medicine. And I welcome you all to the Aesthetic Medicine Digital Series. Starting April this year, we have been constantly working towards planning and organizing such virtual sessions that could help the aesthetics community grow its business and make the AM Digital Series a truly knowledge sharing platform. The exciting element for us has also been last week, where we started off with live sessions on social media as well, on Instagram at our handle Aesthetic Med India. So, with that, do not forget to follow us on Instagram, like our Facebook page, and you could stay tuned with all our social media activities as well. And yes, alongside that, we continue bringing to you our Saturday sessions on Zoom. If you have missed any of our past webinars, I always do not miss out on sharing this, but do not forget to log on to our website, aestheticmed.in. We have most sessions up there, apart from maybe, one or two that we have not received permits to share the recorded sessions for. And today we have with us Dr. Anuya Anil Manerkar, and she's going to speak on upper face rejuvenation with fillers. So I would like to introduce her with a few more words. Dr. Anuya Anil Manerkar is the consultant dermatologist at Panache in Mumbai, an explicit dermatologist and aesthetic physician. Dr. Anuya specializes in providing preventive skincare. She has a strong expertise in skin health through development of corrective methods, controls, and procedures. She is part of the global Allergan complication management team of 120 doctors globally. She has been an Allergan medical trainer in Botox and fillers for 4 years and has been training in threads and lasers for over 2 years. So, with that, thank you once again, Dr. Anuya, for joining us today. For all our attendees, if you see at the bottom of your screen, we have two options, a Q&A box and a chat box. For any questions that you would have for our expert speaker for today, I request you to please key them into the Q&A box. The chat box would be for any feedback or any comments that you would have for me or my team. So the Q&A box would specifically be for your questions for Dr. Anuya that we'll take at the end of the session. So with that, I would like to pass this over to Dr. Anuya to take this forward. So Dr. Anuya, we can get started now. I'll just share my screen and I'll get your presentation started. Yes, Dr. Anuya, can you see the presentation?
Yes, I can see the presentation.
Perfect.
Can we go to the next slide? Yes, dear. Can we go to the contents? Yes. Basically, today we are discussing the upper face. We are covering a few points. Essentially, why would a person consider upper facial rejuvenation? Generally, most people look at the mid face, and the upper face is the part globally which is always ignored. Most people look at the cheeks. As soon as the cheeks develop, the cheeks start looking plump, the contour starts looking good. People ignore the upper face, which is why today we'll discuss why an upper face is also very important. Secondly, how a male and a female looks at aging. How does a male age? How does a female age? What is the manifestations of aging on the upper face? In general, aesthetic goals, how we address the periorbital region. Why does the periorbital region age faster? Then we look a little bit into brow aesthetics, temple remodeling, and last but not the least, injection techniques and the maintenance and case studies. Can we go to the next slide, please? Why do we look at an upper face? Essentially, it's always said that when a woman is younger, a male looks at, or when a person is younger in general, another person looks into his eyes. So you generally tend to see the upper face of the person. But as the person starts aging, you start looking at the lower face because the lower face essentially droops. The upper face doesn't droop so much. So people start looking at you in a different way. Now, the upper face is very, very important because you always make eye contact with a person the first time you meet someone. So if you're making eye contact, the eyes need to look fresh, the eyes need to look good, because the moment your eyes are tired, it's going to be a giveaway to your, it becomes a giveaway. Secondly, an eye, I mean, if you've cried, any emotional state, anything, the eyes always are the first part of the face to show it all. So it becomes the aesthetic center where a person always tends to look at you to estimate your age as well. So it's the region which we use to judge a person's emotional state. Essentially, brow lines, forehead lines, wrinkles, glabellar lines, they're not very pleasant to look at. People start looking very scowly, very angry all the time. So that is something which is does draw a lot of attention. Then comes the position of the brows, the symmetry of the brows. You must have noticed most of the women are very finicky about their eyebrows. My eyebrows round on one side, there's an arc on the other side. People always chase symmetry when it comes to the brows. It's a natural trait right from the time probably beauty and aesthetics were understood. Secondly, when it comes to aging also, the eyes are the first part of a person's face or the person's body which starts aging. You have a scleral show. The white of the eyes starts becoming more and more prominent. So there is a typical scleral show even at rest and at smiling, because generally when a person tends to smile, the eyes tend to get smaller. We tend to have a more positive vector, because the canthus of the eye, which in natural resting state could have drooped down considering aging, would at smiling position always tend to go up. But when there is a scleral show which starts increasing over a period of time with age, and majorly a droop in the cheeks and the temporal hollowing, that is the time when even when you start smiling, you're unable to rectify it and you still continue to remain in the negative vector. So at smiling and rest also, you have a scleral show which is persistent. Then comes your eyelids. Your eyelids start losing its fullness. So that's when a woman starts looking very tired and old. Persistently, you have people asking you, "Oh, haven't you slept? Haven't you slept?" The first two times, the sympathy is nice. The third time, the empathy is still okay. But the fourth time, you really want to scowl. Then comes your dynamics of the skin, whereby you want to consider whether you're losing elasticity, you're not losing elasticity, how are you, whether you have dynamic lines, whether you have static lines developing, whereby they just don't get corrected. Then the volume deficit, which takes place in the orbit and the surrounding structures. Can you go down to the next slide, please? Before we start anything else, we'll discuss very briefly about the arterial supply of the face. Majorly, the face is always supplied by the external carotid artery. The internal carotid artery supplies only a mask-like milieu in the center, which is the central forehead, the upper eyelids, and the upper parts of the nose. Rest of it is all supplied by the external carotid artery, which is majorly the facial artery, which is a part of the external carotid artery. So first it extends into the facial artery. Then the facial artery goes forward towards supplying the superior labial, the inferior labial, and eventually going up towards the nose as the angular artery. The next, from the external carotid artery comes the internal maxillary artery, which basically supplies the lower eyelid by means of the infraorbital, then the buccal, which goes to the cheek, and the mental artery, which goes down towards the chin. Then it extends upwards into the superficial temporal artery. Now, this superficial temporal artery, before it starts off at the zygomatic, before it reaches the zygomatic arc, it actually gives off a transverse facial artery and then goes up to give the anterior and the posterior temporal arteries, which majorly the anterior temporal artery goes into the forehead and it communicates with the internal carotid artery system. Now, this is where your risk happens, and you need to be very careful when you're injecting the nose, the eyelids, the temples, because you can cause blindness. Considering that there is a considerable amount of communication between the two arterial systems, and this anastomosis essentially is around the eyes. So one has to be extremely careful when you're injecting. Your size of the bolus needs to be very, very small. You need to be injecting extremely slowly in a very sensible retrograde fashion and aspirating at every single step for a considerable amount of time, at least like 6 seconds or so. Next slide, dear. Yes. Male aging is always a little It's similar to the female aging, but the female aging is always extremely accelerated. So it's almost 2 to 3 times the rate at which a male would age. The patterns remain essentially the same. It's basically that the mid face starts flattening. The flattening of the mid face leads to jowling, and lastly, the eyelids tend to droop. There is temporal hollowing. Temporal hollowing again is a phenomenon which you see at a faster rate and a younger rate in females. You see it considerably at a younger age in females. When it comes to a male, it's definitely in their 60s when they actually begin to look quite old. Up till their 50s, they're still quite well maintained or conserved, as you would typically say. And then the eyelids droop, the lips become very, very thin. Can we go to the females now? Can you go to the next slide? Yes. So aging in females, again, like I mentioned prior, it resembles the male pattern, but it's considerably faster. It's twice the pace. So essentially, when a female experiences childbirth, you start noticing the volume deficit around her eyes, around her cheeks. Her cheeks start deflating, and typically the nasolabial fossa gets bigger. The orbits also tend to get wider and wider at a faster rate. Considering the amount of intrinsic factors in a female, where there are repetitive muscular activity, because we tend to emote much more faster. Gravity plays a role in males and females, but nonetheless, you can typically say, the males are always better looked after by the females. It's a joke, but to a great deal, if you look at the aging, it also stands true. So basically, if you look at a female, once she goes through childbirth, then the weight gain, then the weight loss, and all of it, and then typically you start noticing her eyes look tired, her mid face starts looking tired, her piriform fossae start getting bigger, wider, her orbit starts getting wider. And classically, if you observe, it's in the anteromedial and the inferolateral position that it starts getting wider and wider and wider. So typically, the first change that you notice is her eyebrow. The tail of the eyebrow tends to drop and the medial brow starts going up. So doing a Botox, an upper facial Botox, which is supposed to be very easy, it becomes quite tricky in a middle-aged female and an aging female, because you want to really maintain apart from the fact that you want to relax our muscles, you want to maintain the aesthetic sense of the brows, and also most importantly, you want to retain the femininity. So in view of chasing her brows or chasing her lines, rather chasing her lines, you can sometimes cause a considerable amount of defect and start making her look like a male, which you don't want to. So you need to be very, very careful. These are the things which you need to remember about a female. Next slide, please. So, manifestation of aging in the upper face. Essentially, like we said prior, it's first and foremost, it's repetitive muscle contraction. Repetitive muscle contraction, weakening of the ligaments, the structures around the ligaments, loss of subcutaneous fullness, bone resorption, a very important point. Females tend to have PCOD, which is extremely common of late. So, bone resorption, which earlier used to happen in our peers in their 50s and 60s or postmenopausal, now starts in the mid 30s. And also in certain females, they have accelerated bone aging, which starts earlier, considering the fact that they have a lot of PCOS. Hyperprolactinemia, hypocalcemia, which goes along with it. All these matters are also the ones which lead to the acceleration. So loss of subcutaneous fullness, typically what you see is loss of subcutaneous fullness, which you see around the forehead, the brow, the temple, upper lids, everything starts looking very bony and hollowing. So the bony outline of the skull, the supraorbital rim, everything becomes much more prominent and evident. The appearance of the muscles, which are typically thin in a female, would start getting bulky and they start standing out. The hollowing of the temples leads to loss of smoothness and loss of the contour, the steady contour or the steady cascade which you generally observe from the temporal crest to the zygomatic arc is lost. Everything starts getting more and more hollow and hollow. So it starts looking more prominent. The cheekbone starts looking prominent. The orbital rims look prominent. The lateral orbital rims start looking very prominent. Can we go to the next slide, please? So the light reflex is also lost. The brow typically descends due to the reduced skin elasticity, the repetitive contraction of the periorbital muscles, and eventually there is a loss of fullness in the upper eyelid. So the upper eyelid starts looking very gaunt. and very sockety. Eyes typically start looking very sockety, and this change happens very faster in a thinner female. In a fatter or a more plumper female, you would still address these concerns a little slower because she still has considerable amount of subcutaneous fat in her temples and the cheeks. But in a thinner female, all these changes are very, very evident at a very faster rate. Then coming down to the intraorbital fat, the fat which is intraorbital and the fat which is retroorbital starts protruding. There is a considerable amount of ptosis because the orbital muscles start getting weak. All the orbital muscles are always thin. They're mimetic muscles. Mimetic muscles are always very thin, and they're more like a fan or a sheet. So these muscles, as they start weakening, they get elongated. They don't get tighter. They get elongated, and there's a lot more space. They tend to droop. So with this droop, what we notice is the ligaments which are normally holding the fat very tightly, keeping the eyes full and nice, start getting weakened. So as these ligaments get weakened, the fat gets pushed outwards. There is a certain amount of herniation or ptosis. Now this ptosis gives us a prominence of eye bags. The orbital rim or the bony orbital rim starts getting more and more deflated and posterior. So as this rim gets deflated, the fat starts herniating. Now, as this fat herniates, we typically get that M or a McDonald's sign deformity, where people have an eye bag, then they have a depth or a crest and a trough. And then again, there is a small eye bag, and then there are cheeks. So eventually people start looking like they have a double deformity or the M deformity. Now, fine and deep horizontal or vertical rhytids start appearing. You typically have vertical rhytids in the forehead. You have horizontal lines around the eyes and on the forehead again, but towards the upper forehead. Now, these are because of the depressor muscles, the orbicularis oculi, the procerus, and the corrugator supercilii muscles. The frontalis, despite being developing lines, is the only elevator muscle of the face which starts it is the only elevator muscle of the forehead. So the contractions tend to pull the forehead upwards to keep the brow in place, which is why these muscles antagonistically start pulling and pushing each other. Also, one more aspect that we should never ignore is the receding hairline and the graying of hair. The moment women start having too much of graying of hair, or even men for that matter, the hairline starts appearing like it's going backwards. And of course, receding hairline, which tends to take place nowadays, it's very, very common. That also adds to aging. People start looking old, even in their mid-20s. You see some young men walking into your office with a receding hairline, and they start looking very old. It gives them that unclish appearance. So working on camouflaging procedures, working on hair loss procedures, where you start working on regrowth of hair, are also essential. It should never be ignored. Next slide, please. Aging of the temple. Temple is one of the most ignored indications, not just in India, globally. People always think that we'll cover it up with our hair. They don't realize the implications on the rest of the face, because working on the temple is also supporting the lateral temporal cheek fat compartment. So you're giving support to the entire face, working with the brow, the cheek, the sides, and eventually coming down to the jaw. Everything improves. It all starts looking better. The whole contour of the face improves the moment you inject the temple. But very few people tend to realize this. But once a person is injected, he always remembers to come back. So here again, it occurs in 3 stages. The first stage is always the beginning, which is the deflation of the fat compartment. So the arc of light which surrounds the orbit is lost. People start looking very sockety. Everything starts looking dull and dark. So the smooth transition, as I mentioned earlier, between the temporal crest or the brow and the zygomatic arc or the bony arc here is lost. As opposed to looking smooth, a female temple is always supposed to be a little concave to straight. It has to be slightly concave. A male temple is always straight, and a bodybuilder's temple is always convex. Or people who indulge in tobacco chewing, or too much of alcohol and tobacco, or night clenching, bruxism, they tend to have hypertrophic temples, which is very, very unaesthetic. Or People who work out excessively or do too much of weight, like I mentioned, bodybuilders prior, that is a convex temple. So the smooth arc is, or the smooth line or the smooth cascade is basically interrupted. Eventually, the tail of the eyebrow starts looking shorter because it gets displaced. It gets displaced inferiorly and pushed posteriorly. So it starts looking shorter. Your brow starts looking shorter, and eventually there is a pronounced volume loss, which leads to a skeletonized appearance. People start looking very hollow and skinny and emaciated. Can we go to the next slide? See, emaciated people tend to have that pinched look on their face. The moment you improve their temples, they start looking better, even if you don't touch your cheeks. So periorbital region. This is just a slight small summary where you have the stage 1, which is minimal lower lid aging. Then comes your stage 2, where there is a slight descent. If you observe, the lid cheek junction starts going below. There is a minimal descent of the lid cheek junction below the orbital rim, just at the orbital rim. Then your third stage, where it goes below the orbital rim. And also there is moderate upper lid aging. There is slight amount of brow ptosis and upper lid ptosis. And all this push and pull leads to a more prominence at the nasolabial fold also. And then comes your type 4, where there is a proper upper eyelid aging. There is a proper lid ptosis. There is a brow ptosis. There is overall lower eyelid laxity. So with the upper lid sagging and the lower lid sagging, you have the round eye appearance, which is the scleral show, the upper lid aging, the lower lid sagging. All of it leads to that round eye. Then a prominence at the nasojugal fold or the nasojugal groove. Then comes your malar bag appearance, which is here. So you have an eyelid bag, you have a malar bag where all your lymphatic drains, and considering the laxity of the cheek muscles also by that time, you have a malar mud, which typically accumulates fluid. And last but not the least, you have the tear trough appearance. Can we go to the next slide, please? Yes. You can observe all the changes which I mentioned to you in this, where you can see the aging of the same female from her 20s, her 30s, her 40s, rather her 30s, 40s, 50s, and her 60s. Can we go to the next slide? Yes. Aesthetic goals are always a little different for a male and a female because the skin is different, the type is different. Here you have a smooth forehead, which is nice, large, convex. You have a small, narrow nose. You have the arched eyebrow. A female eyebrow is always, if you draw a horizontal line from the head of the eyebrow to the tail of the eyebrow, you always want to see arc at a distinct angle. You have the eyes, which are much more open, expressive, wide. You have prominent, full cheekbones. You have a heart-shaped taper in the lower face. You have small upper to lower face ratio. The upper face is always, upper and the mid face is bigger than the lower face. The lower face needs to be a little smaller for a female. Then comes full vermilion lips. Your border needs to be nice, outlined, prominent, and nice full lips which are projected. And then not over projected, no duck lips here. And then you have the obtuse nasofrontal angle. It's always a more obtuse angle, it's open, and then you have a nasolabial angle, which is again a little obtuse. When it comes to a male, it's always a more closed face, a more rigid face, a more tighter face, a face which doesn't give away a lot of emotions, and a face which always is more and more in the moment. So here you have a wider forehead, you have an overhanging horizontal brow. You can imagine a man with an arc. It doesn't look nice. There are very few men who can carry an arc, and it's generally genetic. You have a prominent supraorbital ridge. It's always sharp and prominent. And then you have a brow which is more overhanging. You have a large, wide nose, something that always stands out on a male face. You have a minimal brow arc. You have extremely deeper, closer appearing eyes, a wider mouth, but nevertheless you have thin lips and they're more tightly pursed. You have a square face, a more wider jaw. You have a long square chin, equal ratio of the upper to the lower face. The lower face is wide, it is strong, it's more formidable. You have a beard, you have a closer, more coarser texture, And then your angles are always acute. The nose is more prominent, so your angle between the forehead and the nose, the nasofrontal angle, is much more acute. Also, the nasolabial angle is tight, it's more acute. Can we go to the next slide, please? Yes. Now, this is a case where forehead remodeling was done. If you observe his pictures, the A to the B, C to the D, E to the F, what you will typically see is his appearance in his latter pictures. The B, the D, and the F are much more happier or more pleasant. If you see his pre-pictures, those are the pre-picture ones which are more depressed, slightly more formidable. There is a strong depression between his brows, and the supraorbital ridges are extremely prominent, leading to a more rigid appearance. He looks much more formidable and rigid and angry. He's got a concavity on the forehead, which is not very pleasant. Now, his chin is all right, but as soon as see, we haven't touched his chin, we haven't done anything to his chin if you observe. But the moment the appearance of the forehead was improved, he looks much more pleasant. His eyes look fuller. It looks like his brows have been made more fuller. And if you observe the rest of the face also, the dynamics have changed so beautifully. And we've worked up on his hair and camouflage techniques. So basically, he's been given a little more hair. He's looking so much more pleasant and happy if you observe. Can we go to the next slide, please? Yes. The angle for a female contour, typically, if you measure it along a perpendicular line which you draw in the center, it is 12 to 14 degrees. That's the convexity that we generally want to observe for it to look more pleasant and aesthetic. Can we go to the next slide, dear? Yes. Female temple, a beautiful female temple. Female temples are always my favorite topic. Basically, the contour on the frontal view of the female should be flat to slightly concave. Temples always have to be slightly flat to concave. A convex temple is very masculine. It's going to make the face very wide, and that's not something which a female would appreciate. She would get really annoyed if you make a temple wide. Can you go to the next slide, please? Yes. Aesthetic principles of the periorbital area. Generally, for Caucasians and Africans, they're slightly different, not very. Biometrics are slightly different. Now, here, hyaluronic acid, basically, if you see low eyebrows in attractive faces of all races, the medial brow always has to be lower. The lateral brow or the tail of the eyebrow has to be higher than the medial brow. And you see a more, in case of Korean and Asians, you generally see a more steeper palpebral slant, or this slant is slightly more steep towards the medial canthus. In the other races, it's not that steep. And relatively, the eyes are slightly widely set. In case of most other races, it's always along the line of the nose and the lips. So it's essentially supposed to be within. It's not supposed to be too wide. Can we go to the next slide? Yes. Female brow aesthetics versus male brow aesthetics. We already discussed this, but I'll still reiterate on it. The brow has to be at or above the orbital rim. When it comes to a male versus this, it's always at the rim or slightly below the rim. Now you have a distant arc and you have a classical lateral flare. Whereas in case of males, it's more a fuller hooded subbrow. There's always certain amount of hooding which you observe, and men are always known to raise their eyebrows a little bit when they speak, because the hooding tends to make their, it tends to shut their eyes a bit. So they tend to hold it up. There's always that overhanging brow which you see when you're talking to a male. So there's more subbrow fullerness. It's more fuller, the subbrow. Then if you draw a line between the medial and the lateral ends of the brow, there is typically you see a distant angle in a female, whereas it's much more horizontal in a male. Next slide, please. Yes, treatment strategy. Now, you have two different types of patients who walk into your office. One is your practice where you're restoring, and second is your practice where you're upgrading. So essentially, restoring is that person who likes the way he looks or may want something better, but essentially wants to restore and get things back, where your scale from +2 have dropped down to 0, from 0 to -2, and you want to work back on the scale again. And then there is that younger set of patients who comes to you where they want rejuvenation. They're not looking at restoring. They have a deficient chin, or they have a deficient cheek, or a flatter cheek, or a hypoplastic mandible, or a hypoplastic maxilla, where they want to work on it, or they have a flat forehead or a concave forehead at birth, and they want to work on it, and they say that we want to look better, and if you can improve this, let's work on it. Give me the game plan, and we can start it off. See, the modalities are going to be similar. You are going to work on the hydration of the skin. You are going to work on repair. You are going to work on any amount of photo damage that you see. You are going to work on the contours, the brows, the chin, the projections. You would see the projections in and the proportions of the face, where is the upper one third, middle one third, lower one third, then the projections of the face, considering all the lines, the nose, the chin, the Richter's proportions, the Steiner's proportions. But at the end of the day, your planning is what is slightly different. Here you work on deficiencies first, and then you look at making things look even better photographically. Whereas in the second set of patients, where you're looking at restoring, you first look at restoring, and then if you can improve anything or upgrade anything further, you will look at that and address that as well, depending on the patient's budget. And all your game plan needs to be made in such a way where you can work less and give better results. Can we go to the next slide, please? Yes. So as I mentioned earlier, you would take into consideration the patient's genetics, the patient's lifestyle, the any extrinsic factors. If the patient is smoking, if the patient is drinking, if the patient has any collagen vascular disorders, you would look at all of that. You would see if the patient has any diabetes. You would definitely do a pre-workup and then plan if you want to enhance or you want to restore or just rejuvenate and stop. Can we go to the next slide, please? Yes. Now coming to injection techniques. Please, can we go ahead? Yes. Looking at the forehead reshape. Now, before we start with the treatment, always remember one most important thing, the anatomy. Revise, review, keep revising, reminding yourself, and mark. Always mark your points when you're working. First, you mark your vascular structures. Once you mark your vascular structures, you always place your points lateral or medial to them. So your injections are safer and you have less room to err. So considering that, when you look at the forehead, when you start with the forehead or the temple, most important, mark the medial iris or the medial limbus of the patient. Go up and touch the brow. When you are, if you're in a straight line from the medial limbus, you will observe 200% of the times you can feel that small ostia on the brow, where your supraorbital artery always tends to come out of the skull, and then it starts going upwards. When your artery is coming out, it is very deep because it's coming out of the orbit or out of the bony skull. Now, when it's coming out of the bony skull, obviously it's very, very deep. Now, the artery is not supplying the bone. It's coming out of the bone and it's going up from the muscle to supply from the muscle, the ligaments, the fascia, and the skin. So the artery is definitely going to go from deep to superficial as it's going upwards, as it runs up. And then it's going to give out its small capillaries, which are again going to supply every single area of the area which is concerned. So your supraorbital artery, you mark it, and then it goes upwards. 8 to 11 or 8 to 12 millimeters to be precise from the supraorbital artery, you come medially and you give a crease. You ask the patient to wince or you ask the patient to frown. The medialmost crease that you observe is all the supratrochlear artery always lies in the crease. Here you will not be able to palpate an aperture or an ostium. Here all the artery basically lies under the crease. Again from the bone, it's going to come up into the muscle and it keeps coming upwards more superficially. So basically your injections are always to be planned deep on the bone. So they are extremely safe. And the area which lies 2 centimeters above the brow, these two fingers, is to be left alone. You never touch it because that's where you don't know where your artery lies. It is traversing from deep to superficial. So that's the part of the forehead where you do not address unless you're really an advanced injector who knows what he's doing, and that too after years of experience. But essentially, the best way to approach the forehead, even when we've been old and been injecting for donkey's years, we still try to avoid it. You always avoid these two fingers and you come upwards. So this is the area where you inject deep, straight on the bone. Your needle is always addressed to the bone. You palpate the bone or the periosteum, and then you aspirate and slowly start injecting. Your F1 is your medial forehead. These are the MD codes. Your F1 is your medial forehead, your F2 is your lateral forehead, and F3 is the central forehead. Why is one point in blue and two other points in red? Because the red areas indicate the danger zones, because they lie which in the zones which are overlapping the area of the course of the supratrochlear artery and the supraorbital artery, which is why you're staying higher. You are definitely going to aspirate and be much more cautious and inject. So first you draw your arteries and then you place your points. Can we go to the next slide, please? Yes. And always remember, your injection is going to be slightly at an angle. You do not place a straight vertical needle. You don't stick a needle straight vertically, because that way your needle also, the tip is at an angle. So you're going to be touching with one end and injecting from the other. So you're always going to be slightly higher, which is why you will place it at an angle. You place your needle at an angle so that the entire tip of the needle is horizontally placed on the bone. Then you aspirate and you inject in a way where you are below the muscle. How do you know if your plane is correct? When you inject below the muscle at the level of the galea, on the supraperiosteum, or on the galea, that is the subgaleal plane, you know that you've injected correct when you get this horizontal, when you get a round circular bump on the forehead, which when you press slowly, you give firm pressure, it gets smoother. It's typically a round circular bump which you get, which starts raising upwards as you are depositing the product. But when you inject into the muscle, you have these septae which are running, which don't allow the product to move smoothly. So the product starts going up in a way where it looks like a worm, and you tend to get paranoid and panic, expecting that you've erred and you've injected inside an artery or a vein, which is not the case. It's always the intraseptal injections. You have to break it with a cannula or you do it with your fingers. Now here, what basically happens is, even if you've injected in the plane wherein you're submuscular or intramuscular, it's not something to be very scared of, but basically your muscle tends to get anesthetized and droops. So your brow droops. So on table, when your brow droops and you see the appearance where you have a sun radiating, or you feel like you've unleashed a can of worms, you typically know that you've made an intramuscular injection. The anesthesia is going to work on the layers of the muscle and the brow is going to droop. Whereas if your injection is subgaleal, your brow is going to stay absolutely in place and your patient is going to go home looking like nothing has been done to her. Now coming to the temples. You basically mark the temple. How do you mark the temple? You have a temporal crest which you palpate. It's always wider at the brow and narrower as it gets to the hairline. So you palpate the temporal crest, which is a vertical line, and then you typically draw a line. Then the hairline forms one part of the quadrant. The temporal crest is one border. The orbital rim or the lateral orbital rim is the third border, and the zygomatic arc, the bone here, the bony zygomatic arc of the cheek is the fourth border. So you mark these four borders, all these four borders, and then you make four small quadrants into it, or four small equal parts. So T1 is in your first part, T2 is in your upper lateral, T3 and T4 is never injected, so the question doesn't arise. The lower quadrants are never injected. You always inject closer to the bone because the muscle is thinnest there. Your muscle, you have to understand these, the eyes, when we spoke about the orbicularis oculi muscle or the frontalis muscle, these were all mimetic muscles or muscles of expression. Now temporalis is a different ball game altogether. Why? Because the temporalis muscle is a fan like muscle. It's a huge muscle. It is a muscle of mastication, it's a muscle of chewing, and it's a very deep tight muscle which is going to hold your palate also and your head of the mandible. You need to understand one thing. It's a very thick, tight, deep muscle, and it's so tightly adherent to the bone that your fascia, as it starts extending from the forehead and coming down towards the temples, it is just not going to be able to go underneath the muscle. It has to be at the muscle. It has to be over the muscle. So your injection is typically between the muscle and the fascia. The fascia is the roof of your injection, and it inflates and it stands up like a pillar. That's how your injection is placed. So your temple, which is deflated, starts going expanding upwards. That is the way you are approaching your temple. So T1 and T2. How do you go about your injection points? You mark the temporal crest as I mentioned. Now at the temporal crest, you hold your finger at at your eyebrow, and then you basically, rather than the eyebrow, it's a lateral orbital rim. So you go 1 centimeter backwards and then 1 centimeter downwards. That is your point, which is your T1, your first point. Generally, most of the times we never have to address the posterior temple. It's always the T1 which does the whole trick. It's a slow injection, essentially anything between zero point 0.3 to zero point 0.7 mils. It's a very slow injection with where you hold your needle like a pen, you hit the bone, you slowly aspirate, you have to mark. And as you are injecting, you first and foremost, you palpate the superficial temporal artery. You always need to palpate your artery. Keep your finger in place, which does two jobs. One is your artery is firmly in place. You know you're not injecting into your superficial temporal artery. And two and foremost, you do not allow the product to escape into the scalp because that is gone forever. So you need to hold it very firmly. Now, as you are injecting, always remember you can have some very small and very fine ends of the middle temporal artery. In case you hit it, it's very rare, generally doesn't happen, but in case you hit it, it is a temple, which is, it is the palate which is slightly affected. You may have a little bit of pain in the palate, but over a period of couple of days, it generally tends to settle down. Also, one needs to remember there's a frontal branch of the facial nerve which runs there. So ideally, it's a point where it doesn't hurt the patient much. But also, it depends on the pain threshold, but nonetheless, it's not a point which hurts too much. So when you are injecting, as soon as you place the needle, if the patient suddenly has wincing of the eyebrows and the patient complains of excruciating pain, do not ignore that. Take your needle out. Just take your needle out, pause a little, and then you go back, make your mark again, mark your point, and inject. Always remember you have to inject slightly next to the point of marking, otherwise, you'll end up tattooing the patient if it's a color marking. Then you slowly place your needle firmly, aspirate, hold for 6 seconds, and then slowly inject the temple. Slowly, slowly, slowly keep injecting the temple. As you see the roof expanding, you wait, pause, and then you withdraw your needle. Never inject as you are withdrawing your needle. Otherwise, layer by layer, as you're sealing, you will start depositing product, which could be into an artery as well. And an inadvertent accident could take place, which you do not want. So always pause, stop injecting, and then gradually withdraw your needle. But that has to be a slow process again because you're sealing layer by layer, since you do not want your patient to bleed. Because as soon as the needle is withdrawn, the tamponade effect of the needle is lost. So the patient may bleed, which you don't want. It has to be slow. Next slide, please. Yes, the eyebrow reshape. This is for only for advanced injectors. It is not for beginners at all. Your E1 is the tail of the eyebrow, E2 is the eyebrow center, and E3 is the head of the eyebrow. Here, all 3 points need to be addressed with a cannula and only in the subcutaneous fat compartment. You are not going towards the bone because both the points, the E2 and the E3, are the areas where you find your supraorbital and the supratrochlear artery coming out of the skull respectively. Can we go to the next point, please? Here, yes, one more point I needed to address there was when you are injecting the brows, the amount of product that you're depositing is always very, very less because here less is more. You're just looking at giving a certain amount of eyebrow fullness. If you inject excessive product, you will have brow ptosis, which you do not want. Now coming to the theater free shape. Again, a very common indication, but it's very tricky to inject. Here again, if you need to remember that the orbicularis oculi is a very tight muscle. It is firmly adherent to the bone, especially at the medial end. Now, since it's firmly adherent, it is again impossible to inject on the bone. You're always depositing product intramuscularly. And when you're depositing product intramuscularly, you need to remember that a person who develops teardrop, a person who has eye bags, when you're looking at a camouflage technique, that is the sort of a person where the muscle already has become extremely lax. It's elongated. If you remember, we already discussed this, that the muscle which is like a fan tightly around the eyes is beginning to get looser and it starts drooping. And if your muscle fibers are long and droopy, and you deposit excessive amount of product trying to overcorrect or to just correct right, you are going to deposit more product, and more product is going to droop the muscle more because it's going to gravitate it considering the weight, which you do not want. So what do? You need to always undercorrect. You need to inject very little. Also, if the muscle fibers are elongated and there are fat pads which are herniating, definitely there's space. Now, this space is always utilized by your filler to hydrate because the first and foremost quality of a hyaluronic acid filler is to absorb a lot of water. It can absorb almost 500% to its own weight in terms of water. So it's going to hydrate and gradually settle down in a space. With the tissue integration that happens and the pull and push of the muscle, it eventually settles into a comfortable space of its own. So less is always more. If you need a top up, you can always address the concern. You can top up the patient after about 3 to 6 months, which is all right. But again, like I said, your boluses need to be very, very small. The doses are very, very small. You cannot over inject the patient. The T1 is the central infraorbital at the lid cheek junction. The T2 is the lateral infraorbital, which is a support point. The T1 is the first and foremost pillar of support. The T2 is the vector, and T3 is your medial infraorbital, which is to take away your tired look finally, the grand finale. All 3 points are in red if you notice because all 3 points are dangerous. You have your infraorbital foramen lying right very close to the point TT1. You have your infraorbital artery running its course along the TT2, and then you have the angular artery and a branch of the infraorbital artery at the TT3. So all your 3 points need to be are very, very tricky. You need to address them with a needle or with a cannula in a very tricky manner, absolutely close to the bone. You need to be on the bone. You cannot be anywhere in between. And your injections have to be very, very slow with a lot of aspiration. Can we address the next slide, please? Yes, this is one case study where a person came to a doctor's clinic looking, saying that he doesn't want to look tired. If you notice, his forehead has been treated, the eyebrows have been treated, the eye bags firmly have been treated. There's a slight cheek improvement which has been made because when you're looking at a female cheek, you're looking at a contour. When you're looking at a male cheek, you do not want to contour him too much, otherwise, you'll make him looking feminine. It's more lower, lateral, and the, the, the focus is predominantly on a pull, a more tighter look, as opposed to a more fuller cheek or a more projected cheek. So if you notice, as soon as the workup on his eyes and his forehead have been done, his face looks considerably fresher. The person is looking more younger and a lot less angrier. Can we go to the next slide, please? Yes. He looks much less angry. He looks happier. He looks younger. Can we go to the next slide, please, dear? Yes, this is another lady who was addressed at one of the HGT trainings by us. If you see her, we had a very limited budget. We just worked around her eyes. It is an immediate post where you can even see the needle pricks, but she looks definitely more fresher. Can we go to the next slide now? Yes. Again, a similar case in a younger girl. Here the cheeks were worked upon, the temples were worked upon, and her lower eyelids and the upper eyelids were worked upon. If you see her, it's a younger girl. You would say, why does a younger girl need work? But like I said, like we mentioned prior, you would want, there are certain young girls who come to us for enhancement. This is a similar girl. You see that she looks much less tired and much less angry. It's a more youthful, feminine, and fresher face, despite the fact that the girl is considerably young. She's in her early 20s, but she's already looking so much nicer. Thank you. So here we end our session. And in case you have any more questions and answers for us, we would love to address them. Over to you, Shreya.
Thank you so much, Dr. Anuya. And this is our time. If you all have any questions, please key it into the Q&A box and we would be happy to take them. I can see we already have some comments in the chat box. So let me. Okay, well, I don't see any questions coming in as of now. So maybe if you all need some time to key in your questions, I will do a quick flashback with some more reminders that do not forget to log on to our website for the recorded sessions. Aestheticmed.in is the website. Even today's session, if you've joined in a little late or if you had any network issues at your end, the complete session would be available on our website for you to view. So
If you
please do
look
log
at,
in.
yes, one more point that I wanted to give was product of choice. When you're looking at temple injections, it's always a product which has a high G prime. So we look at something like a Voluma, which gives a lot more strength, where you give a pillar, where the product can stand. But when I look at the forehead or the lower eyelid, it has to be a product which needs to be very thin and fluid, which is going to move very softly and smoothly in the subgaleal plane. So if I'm looking at that, my product of choice is something which is like a Volbella, which is again a product from Allergan. And there is this German product from a company called Biosciences, which produces Genifil. So these are the two products which I generally try to use. Genifil soft touch is what I use if I need to give some body to the forehead, and when I need to give a shine and improve on the contour, I work on with a Volbella. And if I'm looking at the lower eyelid, then definitely my product choice remains a Volbella. I just do not use anything else in the lower eyelid area. So these are, I'm very specific about what products I tend to use. So these are the products which I generally use on these areas. Again, my eyebrow injections, if you look at, my eyebrow injections are generally with Genifil Soft Touch and with Volbella again. Now, recently we have a hydration product called Bolide. That is something which I use to work. I work on the texture of the face or the periorbital area. Again, Genifil has a product called Fine. So that is also something which I use on hydration. And of course, PRP. PRP, we have our ready-made kits which come from Wokat, which work beautifully. So those are the ones which we use out of choice.
Sure. And Dr. Anuya, there's a question on what is dilution of a filler and do you do it for under eye filler?
No, I never dilute a product. The only area of the face, if I have ever diluted a product, was the neck. But over a period of time, I realized that diluting the product was working with the efficacy of the product. So I don't, which is why I told you I'm very product specific. If it's a forehead, it has to be a Genifil Soft Touch or a Volbella. If it is a lower eyelid, it has to be nothing but a Volbella. I only use a Volbella. If it's rejuvenation that I'm looking at for the full face, then it has to be Genifil Fine, or it needs to be sometimes a Volbella, or majorly Volite. If it's the neck which I'm looking at, then again it's Genifil Fine or volbella, or now which with the bolite coming in, I use bolite, but depending on the amount of crepiness that I'm looking at. And I first make sure that I work on the areas with Botox also. So I first work with Botox, relax the areas, except the lower eyelid. The lower eyelid is the only area where I don't inject Botox. I first work on it with a filler, and then I work on the, and I only work with Botox up till the middle crows. Because in case of older women or women where you already notice that the muscles are getting lax, you don't want to inject Botox there and push the fat further. So that is where I avoid it.
There's another question that temple injections are temple injections supposed to be bone deep?
Yes, it has to be bone deep. The whole crux of a temple injection is it has to be bone deep, which is why you never address the lower quadrants. You only inject in the upper quadrant where the temporalis muscle, where the fibers run thinner and thinner and thinner and fuse into the crest. That is the area where you inject. It has to be on the bone because the muscle fibers are thin there. You need less volume. And you're safest because your arteries are also thinnest there. So even if you happen to score one of the arteries, you're still in a safe zone because the lumen is so thin that you're not going to run into complications. But the lower you inject, you need more product. Secondly, your arteries are thick. They are all pulsating there. So the last thing you want is to give a complication. You can make the patient blind. There's always also been a case of pulmonary embolism. So the last thing you want is end into complications. So you never want to inject above the arc. You always go towards the temporal crest and you inject on the bone. Unless you palpate the bone, which is why you need to change your needle when you address the opposite side. Because your needle already gets dull. The moment you rub it on the or scrape it on the bone, your needle tends to get all dull. You have to be on the bone. Your safety is either in the bone or the skin. So certain areas where you're addressing the subcutaneous tissue, you need to be very sure about where you are. And basically, you're playing with the anatomy. Where the artery is deep, you're injecting superficial. Where the artery is superficial, you're injecting deep. That's your whole crux of injecting. To stay away from an intra-arterial injection. To stay safe. It's not just about looking good. It has to be stay safe, look good cautiously. The last
How,
thing you want is to improve a contour at the risk of losing your eye.
how do you use high lace if you have to in some patient?
Okay. See, the high lace which you get in India is bovine high lace. It is not human recombinant high lace. The high lace which you get in the USA is human high lace, which is much more safer to use because it's much more the compatibility is much more. Whereas when it comes to the high lace which is available in India, it's bovine. Any product which is bovine tends to give you much more allergenicity. So the immune response that your body throws to it is much more prolonged or advanced. So basically, you first need to give the patient a test dose. You need to take normal saline, you dilute the high lace with normal saline, then you withdraw from it and further dilute it with lignocaine. There is a proportion. You basically, it depends on the strength of the product which you have used that you would use your high lace. But essentially, what you're looking at is hyper diluting it in such a way that you have every 1 unit of high lace which you withdraw in your syringe tends to have about 30 units of high lace. That is the extent to which you dilute it. So basically, you take 3 cc of saline, you dilute your high lace in 3 cc of saline, and then every unit in your Botox syringe or your tuberculin syringe, every 3 units that you take, you dilute it 5 times with lignocaine. So it's again 1:5 proportion. So it's first 1:3, and then that diluted 1:5. So it's a hyper dilute solution which you're using to avoid excessive high lasing of an area, excessive deflation of that area. You suddenly do not want an area to deflate, right? You want a more controlled deflation. It has to be like chiseling. So one needs to be very patient, and the amount of units of high lace which you're depositing per unit of injection also needs to be controlled, because the last thing you want is your patient on the table to end up into anaphylaxis. So what you do is first you give a test dose. If it suits your patient is fine, you can start injecting. But always remember, despite the fact that the patient did not show a reaction to the test dose, there is always a high probability that with repetitive usage of Hyalase, your patient is going to develop certain amount of hypersensitivity. There will be swelling, bruising, bloating for over maybe sometimes in between a couple of days to sometimes even 10 days. There are some patients who show episodes of contraindication, I mean, episodes where they're really contraindicated, where you see episodes of hypersensitivity even after the Hyalase was used in week 1. Week 2 and week 3 also, they may suddenly get that swelling, settle down. Again, week 3, get the swelling, settle down. So we've seen delayed hypersensitivity with Hyalase also. So one needs to be very careful.
Should the hyaluronic acid filler be always injected below the muscle and the bone, or between the muscle and the subcutaneous tissue, or both?
It depends on the area, it depends on the result that you're looking at addressing. When you inject your product bone deep, the muscle over it always tends to be hyperactive. When you're injecting on the muscle, in the muscle and the subcutaneous compartment, in between the muscle and the subcutaneous compartment, certain amount of muscle activity tends to get slower. This is the way we address a chin, where you see a poppy chin or a more overtly a muscle which is more active, a hyperactive muscle on the chin. This is how we use these modalities to address that. Also, in case of patients who have palsy, we generally tend to work on the side which is overcompensating to calm it down, and the side which is deflated to make it appear normal. So we use these principles, inactive principle in motion, to create the right kind of harmony in the face. So basically, there is no set rule as to whether you are going to inject below the muscle or above the muscle. You decide it depending on the activity of the muscle and the area which you're working on. Certain areas are just non-negotiable. You have to work on the bone. Certain areas you need to work in the subcutaneous compartment in the cheek, non-negotiable. And certain areas, depending upon the muscle activity, you would inject deeper and superficial, or you would inject only deeper or only superficial based on what you're trying to achieve. It's all about what you're targeting.
Sure. What is your technique for injection at temple, gunshot, or fanning, or any other?
Like I mentioned, it's a single point, a gunshot. But it's not like a shot, it's a very slow injection. And only if required, I do a second point on the temple, which is a T2. Otherwise, majorly, if I feel there is a deficit, I again address from the same point, just a little lateral to it. Because you cannot address too much of product in only one area. You need to keep moving a bit, but I never fan in the temples. Never, ever.
If you could please suggest a treatment of deep super sulcus syndrome at upper lid.
Pardon?
Yeah, it's if you could please suggest treatment of deep super sulcus SULCUS
Hmm.
syndrome at upper lid.
No, I haven't addressed that.
Okay, then I'll move on to the next question. What precautions to take to avoid Tyndall effect while treating tear trough?
That is what I mentioned. You need to address very, very small quantities, and you need to be as deep as you can. It has to be a bone deep injection. Any product which is superficial tends to get pushed as the muscle is moving over a period of time. All the product tends to come up because, like I mentioned, the muscle is so tightly adherent to the bone that it is impossible to inject below the muscle. All your injections are by default in this area intramuscular. And as it is, like I mentioned, the muscle is going to get elongated. And with time, get more and more elongated. So it's going to keep pushing the product. So your product needs to have a low G prime. Your product needs to have low molecular weight. It has to be a very thin product with white cross technology so that it blends with the skin. And your product quantity, which is very, very important, has to be very, very less. Your aliquots need to be micro aliquots, very, very small injection points, small doses, so that over a period of time, because Tyndall is something which doesn't, it either comes on table because you've injected too much of quantity, or if your product is not, it doesn't have a, it has a low G prime and it's a Vycross technology. In that case, at that point of time, it looks camouflaged. It looks very nice. And then later on, over a period of time, it starts getting pushed out because eventually you put in more quantities. So more quantities is a major no-no. And then you start having a Tyndall. And if you use any product which is a hyalocross technology, whereby your light refraction, see, there is a Vycross and a hyalocross. When it comes to Vycross, the light refraction is with the undertones of the skin, which is yellow, orange, and red. Whereas if you're injecting a product which is heavy, high molecular weight, a harder product essentially, a harder product. So if you're using a harder product, the product reflects light. The refraction of light is in a way where it goes towards the undertones of purple, blue, and green hues. So everything starts looking greenish. So over a period of time, your product, the under eye area, people come to you to make it lighter, look better, improve the light reflection. And here we end up making it all green and blue. So they look like they have a bruise all the time. And that is something which is very difficult to cover with makeup, because then you have to address it with red lipstick or orange lipstick and then conceal it. Otherwise, it stands out with your concealer standing out. Everything starts standing out as green. And like I said, like I mentioned prior, even with a Vycross technology, despite the fact that you're using a Vycross where your undertones are absolutely with skin, if you use higher quantities, then over a period of 2 to 3 months or later, it starts popping out. And anything which pops out eventually starts looking darker. So people come to you to lighten them, and we make them darker. Is not something which is nice. So your quantities need to be very guarded. It's always advisable to go for a top up after some time, which is a shorter interval as opposed to coming back to you after a year with a small for a smaller dose. That smaller cap is still worth it.
I will have to, conclude this session now. So I'm going to take one last question. We still have a couple of questions. So my suggestion would be that you all could email your questions to me as well, and I would definitely take it up with Dr. Anuya
We
and
can
come back to
reply
you all
to them.
with the responses. But I'll take one last question: that which injection points give a slimmer look to the face? CK1 when injected gives a broader look. So how can we avoid it?
Temples, very important. If you don't address the temple and you start making the cheek wider, what do? You give a Mickey Mouse appearance. So if you want to make the face slimmer, but the patient already has a chin which is looking nice, you can't make it longer and more projected. You'll end up making a look like He-Man. So what do? It's always a temple. It makes everything so proportionate. The moment you do the temple, you first support the lateral temporal cheek compartment. So the moment you support this and then the CK1, the patient already begins to look lifted all along till the chin. The jawline looks absolutely lifted. So your temples, you first work on your temples. The brows get uplifted, the face looks slimmer, then you address the CK1, then you come down, you do slight amount of fanning so that this doesn't look too gaunt. Your CK4 doesn't look too gaunt. Your jaw is already lifted, your face is slimmer. And then you can work on the projections. The rest of the job is complete.
Perfect. Thank you so much, Dr. Anuya. It was a great session. Thank you all our attendees for joining us week after week.
It was absolutely my pleasure.
We will continue, providing this knowledge platform for you, and we will see you soon next Saturday again on our Zoom webinars. But till then, like I mentioned in the beginning, stay tuned with us on our Instagram and Facebook pages. In the chat box, we'd already put in our handles and how you could, spot us on Instagram and Facebook. In fact, the coming Wednesday, Dr. Anuya would be going live with us on Instagram, a different topic this time. So go to our Instagram page to find out what you could find with us, and stay tuned with us in the coming Wednesday on Instagram, and we will see you soon virtually. Take care, stay safe. Dr. Anuya, thank you so much once again.
It was absolutely a pleasure. Thank you, Shreya.
Thank you. Bye.
Bye.
Take care.
Good night.